So let us take some interactive cases with Joseph and see how you got benefit from the previous session.
So Muhammad, if you want to go around the tables, so I'll put a case on, and then we'll go through what Dr. Hussam and Dr. Amr taught us today. So this is the case, 15-year-old girl, and her main thoracic is 57. It goes down to 47. Lumbar is 40, but it's very flexible, bends down to 2. So the lumbar is minor, non-structural. Thoracic kyphosis is 13, and both sagittal profile are less than 20. That was Dr. Hussam was telling us of the upper thoracic. If it's hyperkyphotic, that means it is structural. Even in the coronal, it is below 25. So both upper thoracic and lumbar are below 20, so not hyperkyphotic. So anyone who wants to volunteer to classify this according to what we saw today? It's a simple case. It's no tricks. This is very basic case.
This case is Linke type 1.
Okay.
Lumbar modifier B.
Okay. So Linke type 1 because, so everyone will know.
The main thoracic is the structural curve,
right?
And the lumbar is non-structural curve.
Correct. So it's main thoracic structural, lumbar not structural, upper thoracic not structural, so it's a 1. All right?
Yes.
And it's B because?
It's B because the central vertical line is just touching the apical vertebra of the lumbar curve.
Okay. So it's a B according to the lumbar modifier because the apex of the lumbar curve and the CSVL, your relationship is, A, B, and C, so that's a B.
Thoracic
and
modifier is normal, N.
So N. So it should be 1BN, right shoulder up.
Yes.
Right? So to go again with what Dr. Ahmed told us about Kokkonen. So it's a right curve with the right shoulder up. All right? So this is the classical scoliosis case. It's a 1BN, right shoulder up. So now, decision making. You have to choose the end vertebrae, neutral vertebrae, stable vertebrae. What is your UIV and LIV?
First, this is a Linke type 1. I should see the L4 vertebrae if it is, the angulation, if it's towards the right or the left, because there is a subtype of the Linke type 1. So maybe here I will stop upwards at maybe T3 and downwards stable vertebrae -1, maybe up to I think
so
maybe L1.
Let's go one step at a time. So L4 is slightly tilted,
Yes.
but when you do the benders, it's completely horizontal, same as L3, right?
Yes.
Okay. So so always start by the basics. What are your end vertebrae? So the neutral vertebrae is the one between the two curves that is non-rotated, right?
Yes.
So in this case,
T12. I think this is the
T11, I think. So T11. So this is, see, both pedicles are equally the same. Here it starts to rotate. You see this pedicle is larger than this pedicle. So T11 is the neutral vertebrae. So this vertebrae should be the end vertebrae, right? Because you see here how the disc spaces tilt to the other side. You see here, slightly bigger than here. So that area is in the lower curve. So this should be the end vertebrae of the thoracic curve. So now you have the end vertebrae and the neutral vertebrae. Stable vertebrae.
The stable vertebrae will be the D12.
So T12.
Or D11, the least rotation, D11. The same end vertebrae. Okay.
So this is T11, right? So this is your CSVL, right? So if anyone else has comments about what is the stable vertebrae, which one would you use?
L1,
So you have L1,
L1.
T12. Any other takers?
بس الفيرتيكال لاين سي اس في ال باين شويه لان السيكرال باين سنه
Well, the sacrum male, if you do the end plate, it could be.
اللاين نفسه
Hmm.
لكن يعني I think it's deep 12
So T12 is the closely bisected by the CSVL. So if you take this one is going slightly to the side, so T12 is the bisected by the CSVL, and that makes T11 the touched Teawi vertebrae, the substantially touched vertebrae. Okay? So stable is T12, most substantially touched vertebrae is T11. No, if you move it. So if you consider this line slightly off bend, and if bisects T12, then T11 in that case would be more touched. Because for me, now T12 is the substantially touched and L1 is the bisected. So if you want to consider that T12 is the stable, that makes T11 substantially touched. So, Dr. Amr, which would be your LIV in this case?
Well, I would go for a selective thoracic fusion.
So selective thoracic fusion, that means we don't touch the lumbar part at all. Okay?
Yeah.
So if you read, you have hyperselective and selective, but hyperselective have shown that high failure rates. So selective is,
Selective intervertebral plus 1.
yeah.
So T12, I stop T4, T12.
So T4 because it's
the right shoulder is
right thoracic,
yeah.
right shoulder up,
thoracic, right shoulder up, concordant shoulder
and
blades.
T1 is tilted right up. So it's concordant, right shoulder up, main thoracic right side, T4, okay? So end vertebrae is T11, stable vertebrae is T12, most substantially touched is T11, but you would go for T12. So T4 to T12.
I don't like to stop at T12.
So,
because, just
yeah.
between the thoracic and the lumbar.
So that's another discussion. Can we stop at T12? Because it's in the junctional area. It's the when you switch from the kyphotic to the lumbar lordotic. So Dr. Hussam raised a very excellent point is, should we stop or can we stop at T12?
Who would like to stop at T12?
So this is what we were saying before. Sometimes if you go by the rules, because the rules say stop at T12, right? It is a stable vertebrae, it's end vertebrae plus 1, but sometimes does it make sense to stop at T12? Dr. Sam.
It is okay to stop at T12, but you have to make a little bit flexion, bending the curve a little bit to make it with the harmony with the normal curvature. If you are expert in your hands, you can stop at T11 even also. I will stop at T11 by the way.
So Dr. Sam will stop at T11. Dr. Banna. L1. So you have 3 kind of prominent sclerotic surgeons, and each one stops at different levels. This is the answer to the question that we said before. Most of the times we agree. More of the times we don't. And the 3 of them are correct. So if you go by the rules, he's correct. If you go by the rules, he's correct because we don't stop at T12. And Dr. Banna is also correct because L1 makes more sense. You have a stronger fold. And what are you losing? You're losing T12 L1, which is practically not even very useful discs. So you have a more stable anchor. You minimize your adding on. Muhammad.
And even some advocates that when you go in the upper end vertebrae of the lower curve and you do derotation, this helps to completely resolve the lower curve after a while.
Okay, but then we go
So-
back to what Dr. Hassan was saying.
Yeah.
If you really correct below, that means you're trying sometimes to overcorrect and you lose that self-compensatory mechanisms. So, for the idea of stopping at T12, there's a small note, and actually this I took from Harry Schaffelberger. So Schaffelberger kind of presented on stopping at T12. This is a case from Dr. Schaffelberger, Allah yarham. So is T12 stopping is a problem, okay? So as SRS Flynn posted that we should never add a T12, okay? Because if you stop at L1, as Dr. Banna was saying, you have less DJK, less kyphotic problems, better correction of the cob, and better coronal balance. However, later on, Schaffelberger actually proved that T12 is a good choice for Lenke 1s and 2s. There is no kyphosis at the junction. If you, as Dr. Sami said, know how to kind of really bend your curve in order not to kind of make it flat. T12, though, must be touched by this SVL. So it has to be substantially touched, and you'll get external coronal and sagittal balance. So you can stop at T12, and you can stop at L1. You can stop at 11, but you would have to be really good at maneuvering and derotation. So I stopped at 12, okay? Second case. So this is kind of more complex. And here I kind of put this one because we talked before about the 5 degrees. So you see thoracic is 62, lumbar is 58. But the 58 could be actually 63, and the 62 could be 58. So the lumbar curve goes down to 25. So when we were talking about before about the Lenke classification, Lenke himself said the 25 degrees was arbitrary. They don't know, they chose it because they had to choose a number and they chose 25. So anyone would suggest going, is it 1 or 3?
Any volunteer?
So because the lumbar curve, if we go by the rules, it bends down to 25. So if it bends down to 25, it is non-structural.
There is another very important issue. That's why you have to go to L3. The rotation in the L1 and L2 vertebrae, the apex of the lumbar curve, as you see, with bending, it doesn't correct. So this is an active structure.
Yes, so this is the major difference between these two cases. If you see here, when you bend, actually the lumbar vertebrae, you correct at least one Nashmo, so one pedicle rotation. Whereas here, it is so stiff that you don't get much correction. So there are a lot of small rules you have to worry about. You have to look how flexible your rod is, how flexible your curve is. It is not always about angles, so 25 or 26.
Something to be considered in the lumbar spine when you have lumbar spine curve more than 50, it is a structure.
Yeah.
Even if it's bent less than
So
25.
that is another rule that you don't see much, but it is a major rule. If the curve is more than 50, regardless how flexible it is, you have to incorporate it in your correction. And so distal level. So L4 is very tilted. Dr. Hussain.
And even L5 is tilted.
Yeah.
The way I see this, I always define what the lumbar curve apex is. So the apex here is
2.
L2.
Yeah.
The end vertebra is L. Sorry. The L4 vertebra is the end vertebra. It's not the L3.
Mm-hmm.
So the end vertebra is L4. The apex is L2.
Yeah.
I appreciate and understand attempts at saving L4 and stopping at L3, but honestly,
So these are the benders. So L4 kind of horizontalizes on the bender.
yes. But I will not stop at L3. I would stop here at L4.
Anyone would stop at L3.
Sometimes you can't save. Sometimes you need to go down.
Okay. Dr. Banna. So L4, Dr. Sami.
If you can do good derotation, and if you can do a very good derotation with your instruments and take an X-ray, the AB, and you achieved good correction, you can. But as Dr. Hassan mentioned, Dr. Yasser, revision in this case is very difficult, and you will have especially unbalanced. I will go for L4 also.
So who would take an X-ray when they position the patient? No. When you flip the patient on the belly, who would take an X-ray before they start? Yes, intraoperatively. So when you put the patient on the table, a lot of the times these derotations, when you put the patient on the table, hyperextend, you can actually be surprised how much of that rotation and tilting gets corrected. My second question for the senior doctors: who does X-ray of T1 after correction? So other tricks that you do for shoulder balance, intraop. Muhammad.
T1 is my choice. T1 tilt is my choice.
So you do a fluoro shot at T1
intraoperative.
after you do your correction.
Yes.
I'll do something actually we have more of published and talked about. We use what I call the upper instrumented vertebral tilt. So let's look at this. You want to stop at L4, T4, sorry, at the top, right? Because the right shoulder is
Left shoulder up.
Okay, so I would want to have this vertebra, which is T4, post-operatively more corrected than this, because I want to lift the shoulder up. So I compare the angle here that I obtain at the pre-op tilt of T4 with the post-correction tilt of T4.
Okay.
And I aim at moving it in the right direction. So here I want to lift the left side, so I want to make it more horizontal. That's it. That's what I look at. I also look, of course, at T1, but I also, to me, it's more important to look at the upper instrumented vertebral.
Because that's the one you're actually pulling and moving.
Exactly.
Yeah. So what Dr. Hassan was saying, that when you position the patient, he takes an X-ray or fluoro of the lower vertebrae and the upper vertebrae. And he saves an image of T4, which is your instrumented upper vertebrae, because you're going to do this. So if the right side is up, in surgery, you want to do this, right? So you do a comparative image at the end if actually T4 is corrected. The classical one would be T1, because we saw Dr. Amr saying that the T1 tilt correlates a lot later on with the shoulders. So we do an X-ray of T1 at the beginning and after the correction.
So Joseph, if in the bending views or interaction films that L5 is still has oblique takeoff,
Yeah.
so what is your lower instrumented vertebra? Here it is corrected and horizontalized. If it is still oblique takeoff in 15 years old,
I don't do it. I rarely go to L5. There's a lot of debate on whether you should go to L5 or not. Unless it's a more than 35-degree oblique takeoff, I don't go. Because now we have powerful derotation maneuvers. So a lot of compression, distraction. So even if it's on positioning, I can always try to improve it with manipulating L4.
so you will do your best to stop at L4.
Yes.
There is what's called coronal active realignment. So intraoperatively, if you take a picture at L5 or L4 and you find it tilted, but the spine is, your correction is okay, you can leave it tilted, and later on when the patient starts to walk and move, it can correct spontaneously. It can take to a few months even, but it corrects.
So even in oblique takeoff, you will stop at L4 as well.
As long as it's not a congenital.
Of course, sure.
So another question, when do you tell your patient you will reach your final shape? Because a lot of these patients post-op, when you have sometimes shoulder imbalances, if you overcorrect, the left shoulder might be sometimes up where they had right shoulder up. And this takes time because the brain muscles need to adjust. So how long do you tell your patients, this is not your final look, you have to wait X months?
1 year, 6 months.
6 months, 1 year. So this is another important thing to tell your patients. Immediately post-op, as Dr. Hassan said, you don't take X-rays because these vertebrae need time to adjust. So usually 6 weeks or 3 months when you do your first X-ray, and you tell your patient, this is by far not your final look. You will need 6 months or a year to everything go into place. Muscles will have to adjust. Your brain needs to adjust to let the other uninstrumented parts to take their final shape. And the last case is one of my mistakes. Okay? Sometimes, I don't know what we were thinking, but So this is another case. So main thoracic and upper thoracic, and the lumbar curve is non-structural. So I stopped here. Yes.
The blue line downward
Yeah.
for measuring the cup angle, is L4 included in the curve, or you want to measure from the from
Well, I
L3?
think it's included because the disc L3,
I
L4
see.
is tilted, and there's a very slight rotation still.
I still I see the disc is horizontal. If I measure this, I will stop at
L3?
1, 2, yes.
Okay.
If I measure
So if you measure at L3, that makes it more of a structural
yes,
curve.
Yes.
Okay?
Which one? The lumbar curve, you mean?
Yes.
Yeah.
Do we have side bendings? Doesn't look like that. The problem here is not that the lumbar curve is structured.
Yes.
The problem here is that L4 is tilted to the right. Yes. So they are this so it looks like they lower like King 4 something.
Yeah. So again, if you go by Lanky, sometimes it doesn't fit. Sometimes actually King Mo makes more sense than Lanky in certain cases. So, Muhammad, you would stop where?
L3.
L3. Dr. Banna? L3. Sami? So everyone goes to L3. Yeah, exactly. So this is actually 1 year after. So in the beginning, I know. In the beginning, I was okay. She's good. I managed to derotate. I was powerful, everything, and L1 was kind of accepted, and the patient was fine. And she came a year later. She's balanced, but I don't like the X-ray. But again, she's balanced. I said, as Dr. Banna said, do you want to make the X-ray look better? And she said, I'm happy. Don't touch me.
انا عندي كيس زي دي بالظبط، وانا كنت قايل للبنت من قبل العمليه انا هنقف عند L1 وهيبقى فيه ريزيدوال كيرف وهنعمل له فول. انا عايز اقول بس ان دايما لما يجي لنا حالات الاسكوليوزز نتفاهم مع البيشنت ومع الاب والام بالذات ان احنا ايه هنبقوا اصحاب مع بعض. يعني احنا ايه مش الموضوع مش كده.
صح.
فانا لما اسيب لك ريزيدوال كيرف والريزيدوال كيرف ده ان شاء الله ما يزيدش مع الوقت وانت موفر لك كل الموبايل سيجمنتس دول، اوكي. لو حصل اد اون يو هاف تو اكسبت ان انا may have a second go ان انا اعمل لك كوركشن تاني. ودي نقطة مهمة جدا. لو انت لقيت الاهل رافضين اي كلام من ده خلاص
عمليات مرة تانية جود L3 وخلاص.
لو لقيت في نيجوشيشن وفي كده ممكن.
Okay. So, I think we're behind schedule or?
شكرا جزيلا دكتور جوزيف. So let us go to the back and see on the SOAP1 how we can apply pedicle screw, and you can interact more and more with the faculty to have some tips and tricks regarding application of the pedicle screws.